There we go. Welcome everybody to the BCP Council Health and Wellbeing Board. Firstly, I will just thank you for all coming along, because I know you're not all sort of Bournemouth or BCP based, so some of you had a little way to come. Just firstly, I'll ask our Democratic Services Officer to read out the housekeeping notice.
Thank you, Chair. Please note that this meeting is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. The meeting may also be recorded or streamed for live or subsequent broadcast by members of the public, although ultimate discretion in this matter lies with the Chair in case of disruption. For those in the room, please note that if the fire alarm sounds, please exit the building by way of the nearest available signed fire exit route and make your way to the assembly point at the War Memorial in the gardens opposite the front of this building in Bourne Avenue. Finally, please ensure background noise is kept to a minimum. Mobile phones and other devices are all switched off to silent for the duration of the meeting. And for those in the room, that includes muting your microphones when you're not talking and turning down the volume on your laptops completely. Thank you.
Right, thank you for that. I will move straight on to our agenda. So firstly, apologies and substitute members. So have we had any apologies for this meeting?
Yes, Chair. Glyn Barton has sent his apologies, who I believe has been substituted by Wendy Lane.
Thank you. Welcome, Wendy. Any other apologies? I think.
No, Chair. Oh, sorry, Councillor Wilson.
No, Councillor Kieran Wilson, who I think is on a train on the way to the LGA conference at the moment. So it's a shame you couldn't dial in from the train. But, well, train Wi-Fi is never that great, is it? So that's the reason. Okay, so that's the apologies and substitute members. I would like to welcome Councillor Sandra Moore as a new member of the Health and Wellbeing Board. So welcome. And what we'll do, because I know we have people from different organisations and there's always a few new faces, just go around and just do introductions so everybody knows who's here in the room. So I'm around the BCP Council portfolio holder for Health and Wellbeing.
Louise Smith, Democratic Services Officer for this meeting.
Gillian Key, Corporate Director for Wellbeing in BCP Council.
Yeah, Councillor Sandra Moore, and I've just inherited the new portfolio for, excuse me, communities and partnerships. I'm about to cough, got a bad cold, I'm afraid.
That's Graham Farron, Chief Executive, BCP Council.
Mark Harris, Deputy Director of Place for BCP Place in NHS Dorset.
Hello, Jack Blankley, Community Development Manager.
Hello, Rachel Partridge, Deputy Director of Public Health.
Hi, I'm Louise Bate, the Manager at Healthwatch Dorset.
Hi, Amy Gallagher, Community Initiatives Manager at BCP Council.
Hello, I'm Wendy Lane. I'm the Director for Planning and Transport, and I'm subbing for Glyn Barton, who's the Chief Operations Officer.
Hello, Lizzie Warrington, and I'm here for University Hospitals Dorset on behalf of Shore and Harrington.
Cecilia Bufton, ICP Chair.
Hello, I'm Councillor Richard Burton. I'm the Cabinet Member for Children, Young People, Education and Skills.
Good afternoon, Mark House from Dorset and Wiltshire Fire Rescue Service. Hello everybody, Sam Crowe, Director of Public Health.
Hello everybody, Patricia Miller, Chief Executive NHS Dorset and Vice Chair of the BCP Health and Wellbeing Board.
Great, yes, people online as well. Actually, if we can just quickly, I know we've got a few faces online. Just let me see, Matthew, if you go. Oh, Betty, do you want to go first?
Hi, I'm Betty Butlin, Director of Adult Social Care.
Zena.
Hi, afternoon. Yeah, Zena Dighton, Interim Director of Director for Commissioner in Adult Social Care. Sorry, new post. So I have to keep thinking what my title is. Apologies.
Welcome to your new post. Welcome to Health and Wellbeing Board, Zena. Karen.
Hello, Karen Loftus, Chief Executive of Community Action Network.
Kat.
Good afternoon, everyone. I'm Kat McMillan, Head of Communities, Partnerships and Community Safety at BCP Council.
Matthew.
Hello, Matthew Bryant, Chief Executive of Dorset Healthcare and Dorset County Trusts. Sorry, I'm not in the room with you today.
Right, I think we've got a couple of other faces there as well. If you could introduce yourself, if you can hear me. Oh, it's Sharon. Oh, she's just.
Oh,
Is it
hello.
Scott?
Hi, I'm Scott Saffin, Better Care Fund Manager for BCP Council.
Thank you, Scott. Okay, that's great. Thanks for that. And I think it's quite useful to do that as well, just because we've got public maybe watching or may watch the recording of it. So actually, rather than, yeah, it's useful that people know exactly who everybody is and which organisations we're representing here today. Right, we'll move on to agenda item 3, which is the confirmation of the minutes of the last meeting on the 15th of July 2024. Any comments or amendments for the minutes of the last meeting, or is everybody content? No, I don't see anybody raising any queries, so I assume everybody's content, so I'll sign those as a correct record of the last meeting. Thank you. Declarations of interest. Does any committee members have any declarations of interest? No. Okay. If anything does crop up during the meeting where you suddenly realise actually there's an interest to declare or a conflict of interest at all, please feel free to sort of raise your hand and raise it at that point. Public issues. Louise, are there any public issues for this meeting?
There are no public issues, Chair.
Great. Okay, we can get on to the first main item of business, which is working together to build an age-friendly community for all, the State of Ageing report in Bournemouth, Christchurch and Poole. Try and keep us, we've got quite a number of agenda items today, so I think try and keep us to roughly 20 minutes for each agenda item so that we can sort of have the meeting wrapped up. I know a number of us have got other meetings to go to about 4 o'clock. So yeah, Amy, welcome to the Health and Wellbeing Board.
Hi, thank you. Yeah, I'll try and talk really quickly. Right, thank you. So today I would like to talk to you about the State of Ageing report, which has recently been published, and also update you on the BCP age-friendly communities work that they're involved in. So we're working towards the WHO's 8 domains of age-friendly communities, which they've built to determine the things that need to happen within a community to become age-friendly. So we are really pleased that a couple of years ago we invested and recruited an age-friendly communities coordinator to come into post to help support us. So we're building a really strong local network of partners, and then alongside that we work with the Centre for Ageing Better, which is the UK mechanism for sharing information across around 50 cities and towns, and our coordinator is part of the national steering group for that. And then earlier this year we also became part of the global network through the World Health Organization. And today when we're thinking about older people, the WHO's definition is 50 plus. So it's a good opportunity for us to think about the sort of prevention and wellbeing elements of that, and thinking through the life stages, because 50 plus you can obviously have a number of different generations within that. So think about those that are still in the workplace that might be sandwich carers, those that are planning for retirement, and as well as thinking about how we can support people to stay active for as long as possible and live in their local communities, as well as planning for those health changes, and empowering people to feel prepared for those life eventualities rather than responding to an in-crisis decision. So as part of our age-friendly work, we wanted to create a baseline assessment across BCP to understand what it was like to age in our local area. So we've been working really closely with the BCP Council Insights team that have gathered a lot of the data sources and various data sources to create this State of Ageing report. It's available on our BCP Council's age-friendly web pages, and it's as a slide deck, and also there's an exec summary. And it includes a lot more detailed breakdown of the sort of at a neighbourhood level and ward level. And I won't be able to cover all of the content today, so just providing a sort of brief overview for you. But I hope it creates an opportunity for us to start discussing together how we can provide services and support to help people to age well. So earlier this year, we hosted a number of events through our age-friendly network to speak with older people, and it was facilitated through through Bournemouth University and their peer team, their public engagement team. And we used a 4Ds appreciative inquiry approach to explore what it means to age well in BCP and what an age-friendly community looks like for people. And then at the end of each of the sessions, we also asked people to give their individual pledges about how everyone can take action to help people to age well. So it was a good ending point to get people to recognise that it's all of our problem together that we need to solve. So some of the key threads that came out through those conversations about what was valued from older people was really understanding that sense of community and belonging, the fact that family and the home that you live in is so important to you, as well as thinking about that sort of well-being and engagement. So highlighting the role of communities and those sort of shared interest groups that happen, and those activities like the community gardens or cooking and eating together can really help enhance well-being. When people thought about supportive networks, you really need to have those kind of trusted networks, and that can come through those local groups as well as family relationships, but also things like faith-based communities. And then also recognising the importance of active living, so staying independent through active living, and the importance of a sense of purpose through things like volunteering, accessing open spaces, and also participation. And part of the 4Ds was really about dreaming, and dreaming without any boundaries. So what does an age-friendly community look like? And that's where we were getting some really interesting ideas of things like someone saying, I really want a helicopter in my back garden that takes me from A to B, to really kind of get rid of those challenges that people face in terms of using transport, getting from one place to another. Others love the idea of a marigold hotel. So thinking about everyone in one place, activities to do, that warm sunshine feeling. Sunshine came up quite a bit actually, and having friends around you, and just everything feeling easy to do. Whilst others really dreamt about being in their back garden and feeling relaxed and peaceful without having those mind challenges around the burdens of financial worries and those kind of things. So moving on some of the data, so looking at our ageing population, you're probably really familiar that we've got a higher than national average ageing population. So when we look at 50 plus, we're actually looking at 41% of our population. So 166,000 people in BCP being aged over 50. And by 2031, that's going to be increasing again by 10%. And we're really seeing those increases happening in sort of bulges and waves of population growth. So sort of post-war and 60s baby boomers aged in their mid-70s, and then the mid to late 50s. And there's also a higher proportion of older women, so particularly 85 plus and onwards. The implication for the current needs, as well as the future needs we need to think about around as those bulges move through the life stages. And it's worth noting that by 2030, each of those baby boomer groups will have reached a 65. So the current growth to 2026 is mainly in the 75 to 84-year-olds. And then after that, the majority of the growth is 65 to 74, and then the 85 plus. So our living arrangements are changing and becoming quite varied. There's a lot more people living on their own for a number of different reasons. There's more people aging without children as well. So in the BCP area, 27,000 people, so that's 15% of our population over 66, are single households. So it's a lot. Aging population is also likely to mean an increase in people living with a disability or ill health. So by the age of 75, around half of the population will have disability or long-term physical or mental health condition. And these changes have an impact on our access to social networks and informal care, and the loneliness and isolation to think about, and also affects the types of homes and community support that we would need. There's also an increase in ethnic minorities. So in the census for 2021, there was 6% older people over 65 that identified as a minority ethnic group. compared to 12% aged 50 to 64. So I met earlier this year with the Beautiful Wisdom Group for their first meeting, which is a group of older women over 50 that were joining together from different cultures. And the meeting for me was really uplifting and inspiring because you could really see that people were helping each other and looking out for each other. And they really recognised the importance of wanting to sit down and eat together before they got into a conversation about the sort of community needs and those kind of things. What also struck me was the challenges around language. So many of the women couldn't speak English, but they were helped by others in the room. And it's important to recognise that over 80 languages are spoken in BCP. And we've heard how many, with the many different dialects that exist, it can sometimes not work in the transcription of things and translating things. So, you know, the health and social care words and terms that we use doesn't really kind of always match to supporting people. I also remember hearing a Polish lady speaking about how she's caring for her mother that had gone into hospital who couldn't speak English. And she had specifically provided her mobile number at the end of the bed because she was really concerned about her mother's needs. And when the consultants went round, she was hoping that she would get the phone call to be able to help with that. But unfortunately, that didn't happen, and it led to misunderstandings and misdiagnosis. And it led to the daughter feeling that she had to give up her job so that she could be there to support her mother. And we'll talk a bit later on about the sort of unpaid carers needs that people have. Also thinking about the digitalisation. So whilst we're moving on that trend in terms of things moving online, we are hearing through our community partners that they're spending a lot more time with helping people with their filling in forms and moving online and not being able to access things. And that's alongside people that perhaps are moving online but are now concerned about things like scams or are challenged by the complexity of the applications that are online as well. So being able to maintain offline arrangements and alternatives is really important, and being able to support people as we move through that transition to the next generation with tech. We really need to be understanding our older population at the moment. And also just recognising the other disabilities of things like hearing loss, which increases significantly with age, with men being affected more than women. So is an estimated around 47,000 older people aged 55 plus could suffer from hearing loss. And in the BCP area, 115 people are using British Sign Language as their main language. So financial concerns, approximately 13% of those aged 60 plus are living in relative poverty. And the inequalities really vary significantly across the LSOAs from 2% to 44%. There's a lot that's happening in the news that you'll all be familiar with the changes in winter fuel allowance. Locally, we've been looking at the impact of that. And there's kind of two areas of impact, I guess. Those most affected will actually be those that are just above the threshold. Pension credit is a real gateway benefit to other benefits and savings, and those just above the threshold will be worse off. As well as thinking about pensioners that may have health issues that need to keep their homes warm throughout all of the time. They're really going to be struggling, alongside those that don't that are eligible for pension credit take up but aren't taking it. So there's a whole host of reasons why that's happening, and we've been doing quite a lot of work through the cost of living work around working with independent age previously to try and increase pension credit uptake, and it's also something that we'll be doing again this winter. Decent homes. So gosh, it all sounds real doom and gloom. I'm sorry. It isn't all doom and gloom because we're doing great stuff, but I'm just presenting you with the facts about what's going on. So decent homes, currently around 15% of homes in BCP are classified as non-decent. And the most common reasons for non-decent is around fall risk and excess cold. So falls are a major cause of death and injury, and we know that locally we've got higher than national average rates for emergency admissions and falls, which has been there for a long time. But yes, we understand that older people are most likely to live in the hardest to heat homes with poor or no energy efficiency ratings. So almost a quarter of households aged 66 plus in BCP currently live in energy inefficient homes, and over 60% have no EPC rating. We also know from research that 6 in 10 older people are likely to cut back on their energy usage during the cost of living crisis. So that's a real concern with the recent announcements we've just talked about. And in 2021, 11% of households in BCP experienced fuel poverty. And it's estimated that fuel poverty contributed to 10% of excess winter deaths. But we are doing more, and we plan to do more through our partnership to help people overcome some of those worries and concerns. So we're doing a lot through our Together We Can partnership, and there's lots of community partnerships that we have. So I've spoken a little bit about some of these, but also doing a lot of work really closely with citizens' advice in terms of income maximisation, working with Ridgewater Energy around how do we keep people warm in their homes, sharing information not just online but also through their energy advice home visits and booklets and things to try and demystify kind of what can I do, as well as having things like warm welcome spaces out and about in the local community. There's also things like our Access to Food partnership that we coordinate through our team within the communities team, and I presented at the last Health and Wellbeing Board on access to food, so there's a paper there as well to read. So moving on to thinking about remaining economically active into old age. So we are increasingly becoming dependent on our older workforce. Currently, a third of our workforce are aged 50 plus. Some of this is linked to increased retirement age, but also the necessity to continue working because of the cost of living crisis. And it's really important that we do more to help people to remain in employment for as long as they wish. So we really need to be addressing that through we've been doing some work through training with employers, but it's really about that use of language to how can we help people stay in the workforce. There's a lower proportion of older women in employment, often due to caregiving responsibilities. In BCP, just under a fifth of those are between 50 and 64 are economically inactive due to caring responsibilities. And alongside that, there's also a growing concern about the rising number of people leaving the workforce due to sickness. So we've seen a notable rise in 50 plus that are claiming disability living allowance or the personal independence payment. And the lower income groups are most likely to leave employment due to ill health and concentrated in areas of deprivation. So it really reinforces that importance about flexible working, anchor institutions. How do we change to respond to people's needs as they're in the workforce? We heard earlier about the sense of purpose and the need for being part of their community, and older people contribute significantly to volunteering and providing that unpaid care. So their contribution is increasingly important, particularly when we think about the needs for that informal care and community support, as well as thinking about those aged 85 plus in particular. But we've also know that aging population is presenting those opportunities with the younger older adults coming in and thinking about those that are early retirement and how they may want to get more involved in volunteering. In our BCP resident survey 2023, 18% of residents aged 55 plus had volunteered at least once a month in the past year, which is an increase from the previous survey 2 years ago. And also, when we look at our BCP Council volunteers, a third of our volunteers are over 65. There are nearly 21,000 people aged 50 plus that are providing that unpaid care in BCP. A third provided more than 50 hours of unpaid care a week. It's a huge amount. Right, just thinking about built environment and open spaces. Unfortunately, there's a low level of satisfaction with pavements, which has possibly been a bit of an ongoing challenge, but it's so important for people to be able to get out and about and avoid trips and falls. Also, the design of public spaces is so important. So having access to seating, having sufficient toilets, the absence of these really means that people end up not going out and about or missing out on those opportunities. So the creation of more feeling self-isolated. We're actually doing some work through the Age Friendly Communities Network with Bournemouth Town Centre BID, and they're wanting to do a lot more work in the town centre area around a campaign around take a seat campaign. So not just the toilet use of the toilets, but also a seating area as well. So and they are working with the Centre for Ageing Better, and we may be recognised nationally as a case study for that. So thinking about transport and getting out and about, we know that car ownership and concessionary bus passes will decline with age, and there's more of a reliance on things like community transport. Only half are satisfied with local transport information, so they know how to get out and about. And we know that transport can be a key factor in people missing medical appointments. We're working really closely with a number of different community transport schemes like SEDCAT and others, organisations like Christchurch Community Partnership are putting on their own minibus with volunteers to be able to take people to lunch clubs. So there's some really great things that are happening, but it ends up being quite patchwork across the BCP area about how we're supporting people. The next couple of slides are specifically about health, and I think you're probably familiar with a lot of it, so I'll sort of skip over these bits a little bit in terms of health expectancy and some of those long-term conditions. Yeah, so just recognising that trend in terms of increasing long-term conditions, and recognising that the top 10 is around hypertension, depression and cancer. For me, it was surprising not to see dementia amongst that top 10, but we know that there are around 4,200 dementia diagnoses in 2020, and we've got a very high rate nationally on that. In the BCP area, 80% of those age 55 and over have at least one long-term condition, and that will increase to multiple long-term conditions as people age. So yeah, there's a lot that we need to do to support people. There's a lot that we can do in terms of health related behaviours, and I'm sure you're all sort of aware of the great stuff that's happening through Live Well Dorset and others, and through the Age Friendly Communities Network we continue to look at opportunities to continue this dialogue. But I think it's really important to recognise that behaviour change is really hard to make, and there's a number of different challenges and barriers to that. And we always talk about how can we create that sort of humanising the process and giving time to people to support them through that change. And I think that's a real challenge for us as a system. For our age friendly work, just a quick update on that, and I'm nearly finished. So we're doing lots of things through that network of creating that resource and those opportunities to collaborate together through a number of ways. We've also got ambassadors that are involved in our work, and that's a picture of the last ambassador meeting, and it's great to see that they're wanting to help us with doing more training and sharing information and helping out at local events. We've also launched this year an age-friendly training. So we're doing things around dementia awareness, what's an age-friendly community, and also challenging ageism and language that's used. We've got a joint action plan with partners, and we also do a lot of community engagement and events. And we are encouraging age-friendly practices across our organisations. I particularly liked this, I'm not sure if people saw this, but for celebrating International Day of Older Persons earlier this month on the 1st of October, Louise in our network as part of the Highcliffe PCN, but she's also an amateur photographer, and she took these photos with local residents with those kind of iconic albums, and it really captured the media. So not just locally, but was ended up being talked about on Jeremy Vine and Lorraine on TV, and then also got onto international press as well. So was talked about in New York Post and others. So yeah, it really did grab the global media attention. But it was an opportunity for us to talk about the work that we're doing, and also to challenge ageism, because 1 in 3 of us will be affected by that. So I've put the summary here, but I won't go through it as word to words. But yeah, just really wanted to kind of open it up for an opportunity to discuss and get your reflections on that.
Thank you, Amy. That was really useful, actually. And I think the for me, the statistics and the graphs and the analysis is really useful, because it's often different to our own sort of perceptions and expectations. So it's sort of, sometimes you look at those charts and it's quite challenging in terms of what we think. I particularly liked your comment about the Marigold Hotel, because without getting too political, it could be a future use for Poole Civic Centre, but who knows? But too political, yeah. Sorry about that. Yeah, any comments or questions from anybody?
Go on, I'll lead us off. I think it's amazing the kind of richness of information you're getting through this work, and I'm glad you've tied it back to the JSNA process that the board owns, because that can only ever really be quite high level. But this kind of report actually gets into the details of why it matters to people, and I think you've brought that out really, really clearly. There's lots of things I could comment on, but I do think it's important to approach this from an asset-based and strengths-based perspective, because it's easy to get lost in the more negative health impacts as we age. It's inevitable. You're going to find a lot of information about that. I think the thing that struck with me most when you were talking was that example you gave of the Polish lady who'd left her mobile phone number at the foot of the bed, you know, asking to be contacted. And I'm going to be talking later on about the access to services work that Poverty Truth Commission have done nationally. And I think in response to one of your first questions for us as an integrated care system, what we can do is to spend a bit more time and make sure that we are genuinely finding out what's going on for people and listening to people, and then making reasonable adjustments in how we respond to people so that we see the whole person and their context, and don't just ignore things like a mobile phone number that's been left clearly by someone who wants someone to respond and share what's going on when they're caring for that person. And that's what humanising the process is all about. So there's probably lots of other things that we can do, but I think that's a small adjustment that everyone can make when they're, you know, encountering people, and just making sure they've got the time to really find out what's happening beyond what they see as the presenting issue, so that you're more than just a diagnosis. So thank you.
Thanks for that, Sam. We've got a couple of hands up online. Matthew first, if you could.
Yeah, thank you. So it was a really great presentation. So thank you hugely for all the material you've presented, all the work the team has done. I guess I've sort of got a couple of comments. So the first really is an observation that if we look at the agenda of this meeting today, I think there are some great links between this and other items. So this sets the scene really for a lot of the work of the integrated neighbourhood teams. You've posed a question about the integrated care system. I think maybe a bigger question is, what's the ambition of place? So within the BCP local authority, what's our ambition for this in terms of that asset-based approach that Sam described, with health, local authority and the VCSE working together. And of course, the principles of the Poverty Truth Commission can be used in terms of this work. So I suppose my question is, you've set out really big context, and then you've given 3 priorities for the period up until April 25, which I think are important priorities around engagement, around working with employers, around encouraging social interaction. So
my question is how do we decide on what the priorities are beyond 2025, and how can they really shape our ambitions within the BCP place? So I'm wondering if we want to become a dementia-friendly community. I'm wondering what the tangible actions look like in terms of the implications of this for the built environment, for planning, for transport, etc. And I'm also wondering how we measure success, because one measure, of course, is whether we're complying with the domains of the WHO framework, but another measure might be some population outcomes for our older population.
Thank you. It's probably worth noting that I also presented this recently to the Director of Services Group and within the BCP Council, and there was the similar response in terms of thinking about, we need to think about what are the key aspects that we can bring in terms of the organisations, and thinking what are the key priorities. But I think there's a lot of opportunity about looking at council-wide approach about how we can bring age-friendly practices within those areas of work, but bringing it much more across, which links in with what Sam was saying about thinking much more holistically about the person and how we can respond to them from an age-friendly perspective. And I think from the WHO perspective, I don't think we're too governed by having to kind of work towards like regimented guidance, which is good. But I think there's a lot of opportunities working with the Centre for Ageing Better and sharing best practice about what other age-friendly cities are doing, and we're already doing that, about sharing that best practice. So I think there's some really good opportunities.
Thanks for that. Next, got Betty online.
Yes, thank you, Amy. Thank you. As you say, we've seen this before, and it still has the same impact when you say it again. Just a few things. One of my points was similar to Matthew's. We've got the BCF on the agenda, and within the BCF, we have a strong element, our Better Care Fund, we have a strong element around carers. Carers feature really heavily within the kind of detail that Amy provided. And carers is an area that we know we need to do better on across the Dorset footprint as well as nationally. So I do wonder if there's something there for us to kind of really consider when we look at carers, and how we really embed the whole principles of fulfilled lives and optimizing well-being. I think there are correlations with a lot that's going on. You know, as Matthew said, the INTs, integrated neighbourhoods, the fulfilled lives transformation programme within adult services, and some of the stuff that Newton have told us. And for me, I think it's really, really important that we bring this back to our workforce as well. You know, we heard the stats around our workforce and the amount of our workforce that are carers and over 65 or over 50. I think we need to be really sighted on what we're doing for them to keep them in work, but also to keep them having fulfilled lives in the roles that they're doing. And Amy, just finally for me, it's about how do we really use this report, the wider report, to inform us, set some of our agendas as we go forward. Because I know from some of the national data that we have an increased number in people coming into our services who have a long-term conditions, both carers under 65s and over 65s, and that is really impacting on what we're able to deliver. So I think this is so useful for us that we need to focus on maybe 2 or 3 key areas and then come back to the others. But such a helpful report. Thank you.
Thanks, Betty. Next, Patricia. I think you indicated you wanted to.
Thank you. Thanks for the paper.
Got your microphone. Sorry.
Green, red, green at Dorset Council, ready. It's all confusing. Thank you for the paper. It's really good. I've just got a few thoughts that on the lines of Matthew and Betty, but a bit more strategic. So first thing is, when we talk about language, we know from the research done, nationally that the average reading age in this country is between 9 and 11. So there is something about not just making it culturally sensitive to different communities, but recognising if we want best practice, that's where we need to aim the language of a lot of our literature at. When we talk about wanting some of the language to be culturally sensitive, there's something in my mind about talking to different communities to help them do the translation, because the access to health and care will be different in all sorts of communities over the world. And so people need to relate what they know from where they've originated from and then translate that into how care is accessed here. There's something also in my mind about how do we connect this work, not just through place and the INTs, but in general to the Joint Forward Plan. Because in the Joint Forward Plan that was developed by everyone that sits underneath the integrated care strategy that Sam led on, there is a strategic objective in there about helping people live longer independently and healthy years. So how do we connect these two pieces of work so they're not divergent from each other? When we think about deprivation, and you've mentioned a lot of it in here, that not only do deprived communities have a much shorter life expectancy than affluent ones, communities that originate from global majority communities also have a life expectancy of 20 years less. Now, that's not about anything in terms of, particularly in terms of lifestyle, it's about other issues. So how do we recognise that? And how do we do things that connect into the prevention agenda, that move interventions further upstream? So what we're doing is tackling that, and then we're dealing with one issue around life expectancy. And then there's something else around getting the balance right between employment for older age, but also wanting to retain young people, because we tend to do things in silos in our system. And if we only concentrate on employment for older people, then what we're doing in some cases is using the employment space to keep younger people in our system. And the reality is we're going to need them not just to be employees in public service, but also to fulfil the caring agenda that we have later on. Recognising also that this is not just about talking to employers about jobs, it's talking to employers about being age friendly. And we can learn a lot from places like Japan, where there isn't age friendly communities, where supermarkets have age friendly areas. There's a whole conversation there about how who taps into all those different forums. And then the last thing in my mind is doing this work in the context of what we already know is about to come in terms of the 10-year Health of the Nation plan. Because what's becoming really clear is that plan is not going to be an NHS plan. That plan is going to be about how do we keep the nation as healthy as possible, so we're moving into the best start in life, optimism for the future, healthier life years towards the end. So what we're creating is a thriving economy. And so we can anticipate some of those things already. So how do we keep developing this in that context that we know that when that plan comes, we're already ready to lift off in the way that the new government wants us to?
Thank you.
Thanks for that.
Yeah, thank you. Really helpful.
Thanks for those. Unless anybody else has got those really useful contributions from Patricia and Matthew, Betty and Sam, I think just to sort of reflect the sort of presentation you've given. Any other sort of questions or points that anybody wanted to raise? Well, I am conscious of time, but thank you very much, Amy. That's really useful. And I've seen some of those slides before and statistics, and I think we've got a few recommendations in the report. I won't read them through, but it is recommended that board members recognise the contribution that the age-friendly communities are making, use the insight from that State of Ageing report to understand demographic issues of our older population and facilitate work between the older age-friendly communities partnership and system partners. I think particularly B and C for me are the sort of important ones there about actually taking that forward and actually using the insight and the information there to actually inform what we're doing, to be aware of those issues and actually make sure that our system partners are sort of using those report findings to respond to it. So I think that's really useful for me. I think I haven't got any questions particularly, but my only comment was I think over 50 now, and I think there's always been public interest about sort of aging well and health, and that's as you get older. But I think I sat down over the last couple of weeks watching the BBC TV show Paddy and Chris road tripping, and there's lots of TV travel shows. But I thought what was interesting was on that one was it is about they just passed 50, and it's like, well, how are we going to grow old? What does the future mean for us? How are we going to be healthy? And it was you know, loads of TV travel shows, but the whole focus of that was, well, what do we need to change in our lives to make sure that we're staying healthy and actually, and they used a phrase which I've heard here before about adding life to years rather than adding years to life. I think Sam's used that phrase before, and they seem to say it came from some Greek community or something, but I thought, nope, I've heard that in BCP. So, yeah, it's in our corporate strategy. So I should write to Paddy and Chris and say, actually, it's still not from Greece, it's from the BCP corporate strategy. So yeah, I think that just for me indicated the sort of public interest in that area. So thank you very much for that. Sorry for my slightly offbeat reflections on that. Right, we'll move on to agenda item 7 next, if that's okay with everybody. Integrated neighbourhood teams, which I know has been a sort of topic of conversation for a while. I've got, I think it's Matthew online. Are you presenting this with Jack in the room? I don't know how you want to do.
That's right, Chair. So I am the stand-in today for Nick Johnson, who's the lead executive working with colleagues across the integrated care system on this programme. What I'm about to present, colleagues such as Gillian and Betty have been involved in the development of this, and the plan is for me to talk to the first few slides before handing across to Mark and Jack. Can I ask, is somebody kindly going to display the slides? Is that possible? Otherwise, you will be relying on my IT skills. They're in the pack.
Let me just have a look. We'll see if we can facilitate that.
Is that okay? Thank you. Thank you, Jack. Okay, so just remembering I am the stand-in, I will begin. So if we can go on, please, to our ambition statement. And so the ambition is about how we deliver more integrated care, which is really from starting with the perspective of the NHS, removing some of the barriers that we've got between sectors of care and working with partners, including the local authority, including the VCSC, in a much better way to meet people's needs at a local level. I think it's a particularly important day, actually, to be talking about this, because, of course, today is the day that the new government are launching the consultation on the NHS 10-year plan to be published in the spring. And much of what we're about to talk here is really what that plan will be addressing in terms of what neighbourhood care looks like. So if I go on to the next slide, it's important that we see the integrated neighbourhood teams very much in the context of place. And so what this element of work is doing is really developing those teams to ensure that they are integrated, they are multidisciplinary, they're working at the level of neighbourhood, which I will describe shortly. It is not the programme that addresses all of the wider determinants of health at the level of place. So understanding how this work links in the context of a strong and effective place-based partnership is very important. And there will be things, important things, to be done from the perspective of health at the level of place, which will need to be discussed and agreed through the place-based partnerships rather than broken down to the integrated neighbourhood team level. If we go on to the next slide, I think it's also important to say that the concept of these teams are not new. It's something as a model that has been talked about in the NHS and indeed more broadly for some time. It's something that actually, as partners within the integrated care system, we're well placed to achieve in terms of building on some of the work that has been done locally and not least within the BCP area. But at the same time, there is much to do to actually achieve this vision. So again, this is a broader conversation than just the NHS, but if we look at the NHS family, there is a lot to do to simplify current fragmentation and barriers between services that stop things feeling integrated, that stop the NHS feeling like one service at a local level. The final thing I would say about this slide is the vision here really is very much in line with the comment that Sam made earlier of an asset-based approach. So the integrated neighbourhood team, which you've sort of got a schematic picture of, is very much about bringing the assets that are found within the NHS, within general practice, within the VCSE, within the local authority, within communities themselves, and then saying collectively, how can we use those assets, those team members, in a more effective way to meet the needs of the population in this area? So if we then go on, and I'm just going to talk now about the journey that we're on, and we're starting really on the left-hand side of this slide. So at the first part of this, inevitably has an emphasis on health, and if you like, the health family getting its act in order. So I would describe this in number terms as sort of 70–80% about health, the health family, and 20 to 30% about the things outside. And then that balance shifts over time. So by the time the teams are mature and up and running, I expect that balance to have shifted around so that actually 70% of the conversation is about some of those wider things that we heard about in the previous item in terms of the determinants of health, and 30% of it is about the health family. But the focus here and now to get it off the ground is about how we're doing some of that reorganisation within health in the context of our relationships with others. So if we go on and to the next slide, please. So this is now about what's in scope immediately. This slide really is a reflection of what I've said about a programme that's focused on realigning and integrating the NHS elements of neighbourhood care. And we're taking a number of steps to do that in terms of looking at contractual and operational processes, time into the development of neighbourhood teams, putting time into our partnerships. And again, that's reflected in the picture on the right-hand side. So if we go on, to do this, we've got a development journey which essentially is being rolled out in every area, where we start with the conversation about what matters to our local population. We make sure that that's data-based as well as based in the lived experience of citizens. Again, much in line with the Poverty Truth Commission or the ICS working with 10,000 Voices. It's that methodology that we're bringing. We then look at, within the neighbourhood area, how are things currently organised to deliver against needs and priorities, and then take some changes to the organisation of those teams so that they are working more effectively to meet the needs of the local population, but very importantly are also delivering the shift from a model of treatment to prevention. And of course, again, in Dorset, we're very well placed to do that because of the data that we have through the DICE system, which actually will allow us to follow that path at neighbourhood level. So that's really the approach that's being taken at each level, at each neighbourhood level. And we're currently working with the National Association of Primary Care to get expertise from outside the Dorset system to help us develop that sort of schematic approach to work with each local neighbourhood. That's reflected on the next slide, which goes on to set out the first 4 areas that we're working with. So within the BCP area, those are Boscombe and Poole West. And again, I was struck by one of the slides that we saw earlier, which showed healthcare inequalities and some economic data. And I think that both Boscombe and Poole West would be indicating as areas of relative deprivation within BCP. And that underpins in large part why we are starting in those areas. That's the work that we're doing at the moment, and we'll hear more about that in a minute. If we go on to talk about the INT footprints within Bournemouth, Christchurch and Poole, and we go on. So here we are, which is a map that will be familiar to many members of this group because it's a map of local authority ward areas. And essentially what we're trying to do is to align services around these natural communities, and therefore essentially again it's about the health family actually reflecting some of the natural community flows and boundaries that we get, which is why we've come down on the side largely of the local authority wards. And again, with many thanks to Gillian and members of her team who've been involved in this part of the discussion. So going on then to the approach to measurement. So essentially, we are going to have programme-wide and local measures. So this is the core measures and the locally relevant measures. And going on to the next slide, the measures that are going to be common to all areas are essentially these 4 areas, which are about staff activation. So how staff are feeling about their work, and essentially the question about recommending their organisation as a place to work. There's lots of data to show that if that measure is high in terms of healthcare, it will equate to high quality of outcomes. A patient activation measure, which probably should be called a population activation measure. So this is in a sense for the citizen, to what extent does a citizen feel in control of their health, measured through the question, how good are you at taking care of your health? And again, there's lots of evidence to show that if those rates are high or rise, your outcome rates will be good. And that's a proxy really for things to do with both physical and mental health. And again, relates very much to the conversation that we were having about older people, because if you are engaged in your community, if you're feeling empowered as a citizen to act, for example, in accessing health through digitally, through a language that means something to you, as it were, your patient activation score will rise. So it's a very well-trodden path in terms of a measure. We're also going to measure demand reduction, and that will be, I'm hoping that's across health and social care in terms of numbers of contacts. And again, lots of evidence to show if we get this right, the social care bill, as it were, will fall over time because people will need less care at any given point in their health journey. And a number of technical things around health improvement for both physical and mental health. So those are the things that we're measuring. They've been developed in conjunction with teams and also the National Association with Primary Care. So that's really the framework that we're operating in. I'm going to pass across now to Mark, who will then pass to Jack to complete the presentation.
Thanks, Matthew. So just sort of to build on what Matthew said, really, I think from the BCP Place perspective, we've identified the 2 sort of development areas, if we call them, to be around Boscombe and Springbourne, and also what we're terming as Poole West, which is the sort of the couple of wards towards the west of the place. The slide that's up there at the moment really just gives you a sense of where we've got to at this moment in time, which is around the sort of the yellow purple boxes. And if I go on to the next slide, just to talk about Boscombe and Springbourne particularly, which we've moved further forward with. we've held, as Matthew said, we're sort of focusing on the health integration. So we did have an initial conversation with wider stakeholders in the room to look at what are the particular priorities that we need to be honing down on, what were the particular challenges and barriers, and the areas that practitioners on the ground are struggling with that we might have opportunities to sort of move forward with. We've subsequently then sort of drilled down into the health piece around sort of that health element of, we've got disparate services between primary care and secondary care. How do we sort of help them to work better together as one? And the latest position we've had in that is, again, sort of building from the bottom up and listening to what staff are saying, but also using the data insights, which were also sort of referenced earlier on, is things around mental health, but particularly looking at depression, long-term health conditions. A particular area is around diabetes in the under 40 population has come up as a sort of a flag. And addiction within that footprint as well is something people are saying are opportunities where we can actually bring people together to work in a different fashion, but also enable people to tell their story once and get the right support and care the first time without being passed from pillar to post. Homelessness is also live at the moment in terms of that conversation. So again, that has an overlap with the addiction piece and also with the comorbid mental health presentations. Immunisation and vaccination and children and young people are the other two areas that were also discussed. So where we've got to at the moment for the Boscombe and Springbourne piece is really just identifying those people that are in those frontline teams to bring them together. So there's a plan to bring them together in the next 2 to 3 weeks to sort of get under the skin really of those particular areas and how we can do things differently. So really, it's not to underestimate the sort of, I guess the other bit around this is the cultural aspect of it. So thinking about teams who've worked in a certain way for a long period of time. And often there's relationship challenges between different parts of the system as well. So really it's about bringing them together to try and sort of unpick some of that, set the principles by which we want to work by, and start looking at what is that operating model to sort of take it forward. Jack's going to talk about the sort of the community piece in a minute, but I guess it's just important to sort of put a flag to the fact that these will be two parallel pieces. So again, the integrated neighbourhood team piece is looking at the here and now, for as Matthew said, around sort of the reactive piece. How can we do that better? How can we deliver better outcomes and a better experience of care? But alongside that, we will be doing the community engagement piece, which Jack will go into to inform the wider pieces of work that we've got to do around that neighbourhood. Just to talk about Poole West, just briefly, I suppose that's just to sort of give you an illustration of where we're talking about. It is 3 wards. Again, there's some specific demographics within there, and we've just reached out to colleagues across. So I suppose people will be familiar with primary care networks, which they're not coterminous with the ward basis. So we have a number of different primary care networks. So we're bringing all those partners together with colleagues in community services as well to just lay those foundations, get any elephants in the room on the table, and start to work our way through around how we might change how people work together. So I'll pass over to Jack to talk about community stuff. Thanks.
Thanks, Mark. Yeah, so community engagement workstream. So I'll give you a sort of a bite-sized look at the work that we're doing here. But I guess the first question is why? Why do you do a community engagement piece of work around something like this? And I think one of the things that was created early on in this project was some really good data packs, which provided some really fascinating data based on those local footprints of the INTs. And I think that data was public health data, BCP data, NHS data, and it was really, really comprehensive. But what we have to remember is behind each one of those bits of data is a story. So if it's somebody with a long-term condition or with something, there's a story behind what could have prevented it or how it happened or what it is. So this piece of work is really aimed at engaging with people in those INT footprints to understand their story and to use that data and to present it to the INTs, but also to this board or the place-based partnership, so that you can have on-the-ground local intelligence coming from the people in the communities. So what are the objectives of the community engagement workstream? So it was obviously to develop a model which we'd be able to replicate 9 times across the INT neighbourhoods in BCP. And we really focus on providing that qualitative data, so which I just discussed about. We had to ensure that the model had to be replicated across BCP. There's no point creating an all singing and dancing one in Boscombe, which then takes all the resource to be able to do it in other places. So we wanted it to be able to be moved across the areas as the development of the INTs went on. It's obviously needed to be resourced effectively and delivered on time, so we haven't had any additional resource, so we're relying quite heavily on working with our NHS council, but also our voluntary sector partners in able to deliver this. It needed to be co-produced and to work across both voluntary sector, health and BCP council. And it needs to be developed alongside other work streams, such as the development of the access to wellbeing hubs and data packs and workforce mapping. So this is the approach that we're taking, which we'll replicate 9 times. So the first is to establish a working group. So we've got a core group of organisations from BCP Council, NHS, then we've got key voluntary sector organisations such as Help and Care, CAN, Healthwatch Dorset we've spoken to as well, in order to design that co-produce that survey and that approach. The next is when we're working in individual INTs, there's going to be local groups which are very specific to those neighbourhoods, who it's really important that we engage with and work with on this. So if we're working in Christchurch, we do Christchurch Community Partnership would be an important partner. In Poole, it might be Poole Communities Trust or Poole Communities Trust. So it's about, again, understanding that local insights about what's happened before and using those existing assets to build on. The next stage is a broad approach. So again, producing a BCP-wide survey which can ask those sort of person-centered questions about their lives, so that we can achieve a sort of sense of saturation across each of the 9 INTs. So some of the questions are, how good are you at managing your own health, and asking people to rank these. And I think that will, again, allow us to reach as broader number of people as possible. Then the next is a deep dive. So building on the 100 conversations model, we're looking to replicate that across the INTs in Dorset. So we want to achieve hopefully 10 community conversations across each INT area. So again, and what we want to do is that core group is to identify which a good wide-ranging stakeholders in that community. So do they access healthcare? Do they not access healthcare? Are they part of a particular community which is important in that area, so that we can really get a really diverse amount of information about people's own ideas around health and wellbeing. And then finally, it's obviously reporting back. So reporting back to the INT to help them develop their strategies for engaging with local residents. Reporting back to place as well, whatever place is, in terms of either the place-based partnership or the health and wellbeing board, because there might be some fundamental things which have come up there which can't be answered by INTs. So if there's a particular thing around housing or employment, and is that something we want to bring to here? And then finally to the local people themselves, making sure that they're involved in that process and potentially then use their expertise and knowledge to build on ideas themselves. So yeah, just show you briefly, this is a breakdown of each individual activity where we're going. So providing those one-to-one meetings with support with community, key community partners in those areas, survey design, and the survey design, it really has been a co-produced piece of work. We've worked with NHS, Public Health Dorset, and Bernadette has done a really great job in that project, Help and Care and others. So we really have tried to make sure that everybody has ownership over that survey, so that when it comes to delivery, everybody feels that they can contribute and is part of it. And then, as I said, the deep dive conversation. So we're on Thursday going to train another 10-ish people from BCP Council and the NHS to deliver the community conversations, so that we're able to do that and do hopefully 90 across the BCP area. And then analyse and report, as I've just said. So today we've talked quite a bit about asset-based approaches and asset-based community development. And some of you may know this ladder at the front. So it's called the ladder of participation. And it's how you can judge how engaged or how each community intervention is working with the community. So obviously the bottom one you will want to avoid, because we're not in terms of coercion, but the next one's doing it for. So it's obviously think about a traditional way of doing something for a community. The next is doing it with, so traditional sort of co-production, and the next is done by. So that's a asset-based community development approach. So this approach is very much in the middle of that at the moment, and it's really important that we're open and honest about that, because it is about collecting those thoughts and developing those relationships between the INT and the individual communities, because it's the relationships there which will enable the work to increase that ladder. And you can't jump to the top of a ladder. They involve going through steps. So it's really important that when these INTs are developing, we are in that stage of that lower middle part, but the intention is that we'll be able to move up to the top. So I guess I had two questions for the Health and Wellbeing Board, and one's around ward councillors. So how does the board feel that the development of INTs and ward councillors who obviously play an important role in their communities, how should we involve them? And then I think the next question is the more important one, but when designing this survey, it's fair to say we had a couple of colleagues who felt a bit surveyed out, as in they've produced a lot of surveys in the Times and the recommendations are perhaps not listened to in the way that they felt they should. So my ask is, how do we ensure that INTs, I'm not saying adopt every approach that's possible, but it needs to be better acknowledged and at least worked on if we can. And also for this board or the place-based partnership, if we're going to have recommendations from the community, how do we ensure that we acknowledge them and work with them on places where we see we can?
So thanks, Jack. And then just in terms of conclusion, Chair and members of the board, I think what we've presented today is, having had this as a topic of discussion for some time, I hope people feel that you've now got in front of you a tangible programme where the ideas really have been developed. We have got engagement underway, and it's really good to hear those themes coming through from Boscombe. We've got an idea of the geographies we're working with. We know what it is we're going to measure for the programme as a whole. As Jack has sort of concluded with, when you're working with that kind of ladder of participation, the co-delivery, co-production bits, which we want to do, inevitably take a longer time than just informing or coercing communities. And I think the team have made really good progress in terms of engagement. What I would hope is that the next time we give an update in a few months' time, we'll be able to bring back those stories of Boscombe and Poole West and actually give some tangible data and narrative on changes that have been made to services in their organisation, and then what we're beginning to see in terms of outcomes. And I think that will help us answer both those questions that Jack has posed. I'm a bit more optimistic about the second one because I think that we'll get momentum behind these conversations, but I'm really interested in that question about the role of councillors and how people want to be engaged in this work. I think it's a very important relationship.
Okay, thanks for that. Jack, if you could turn your microphone off. Thank you. Patricia just wanted to comment quickly before we.
Thanks, David. So thank you, Matthew and colleagues. That was a really good update in terms of where we are. I think there's something about us understanding where this sits in the national conversation, and not just about the NHS, but the likely update from government on the importance of place and neighbourhood. So what is really clear is that the model of the NHS delivery needs to change if it's going to become affordable. And so there is going to be an intentional shift in more work being done out of hospital and less work being done in hospital to start first reducing the overall cost of the NHS, but also that out of hospital model moving very quickly into prevention space that starts to produce results around a healthier population, and so more self-management and a reduced cost to the public purse. It's going to be linked to economic growth, as we know, through the 10-year Health of the Nation plan. So us being ahead of the curve in this space is actually really exciting, but it's also really important. I think there's something we need to think about. The questions that have been posed are really important because I know that the whole premise behind place is ceding authority and responsibility to communities, which in local government you'll find easier. In health has never been done. So I'm quite up for that. Whether all my colleagues are up for that is a completely different question. And how do we move into that space of really co-producing the answer in the out of hospital model to health and care and the wider determinants. And that means we do have to hold ourselves to account, actually, that when our public tell us they need something, because they understand their lived experience more than we do, that we go along with that. And if we can't go along with it because it's not affordable, we have a sensible conversation that helps them work with us to prioritise what is important. So I think we've been involved, as Gillian knows, in some work, some research with the NHS Confederation, with an organisation called the Local Trust. That has been around researching what real neighbourhood working can deliver beyond the health and care question into building on community assets, so building and developing more social capital. What does that then mean, not just for economic growth, but for the health of that population to improve? And what we know from that research already, we've only had the first wave of the results, is that some of this you will already know in local authority, that one, that the way that we engage communities is by drawing neighbourhood boundaries that they recognise as neighbourhoods. So that's not what we recognise in health as PCN boundaries or what you recognise as ward boundaries. It's what they recognise, because that's where they see the assets and capital that they might want to build on, and the experience, because they already have the existing relationships. That will be a challenge for us, because that's not how any of us work, but it's important that we think about that. And I've already given the message to our primary care networks that actually those what are effectively working barriers for them but false boundaries for our community may need to become irrelevant in this space of how we might work in an integrated neighbourhood level. What we also know from that research is that working with communities and listening to understand and then building solutions that they need, that they articulate, is really important. And that's really difficult for health, because health has for 75 years taken a very paternalistic view to how it manages the community's health needs. And for us now need to step into a different space is even more challenging for some of our clinical bodies. So I think that the questions for us are, yes, how do we make sure that we build on the recommendations and listen to understand and respond to what our communities ask? But I think the next layer is, how do we move from what Matthew's talking about, which is a health and social care model, into something that is much broader, that builds on community knowledge and experience and assets, and gets us into that wider social determinants conversation that we're all having in different pockets, because a huge amount of primary care's time is spent on social issues that are not for them to deal with, but are the consequence of that is poor health. And if we can get into that wider conversation where we're all working in an integrated way in that space, primary care can do what primary care needs to do. Local councillors then won't be facing lots and lots of issues and complaints about people not being able to see their GP, because they will be doing what they need to do and being able to signpost people to other parts of the system really quickly to get those wider determinant issues addressed.
Right, thanks for that. Just to give a bit of context, I mean, I think it's the Health and Wellbeing Board is just asked to note the progress it's made, and I think it's a really useful update on in terms of where we are in developing within the integrated neighbourhood teams within BCP. But any comment?
Have we just lost the room?
Yeah, I think so. Yeah, I think so, Matthew.
Oh,
I'll put it in the chat.
I
Shall
thought it was me.
No, I did. I was looking at everyone else on the screen
Is
thinking,
anyone else moving?
I'll,
I thought it was
I'll just
me.
put
I
it
was
in.
about to raise my hand.
Yeah,
As well.
we can't hear on screen. Can't hear anything. Screen. Okay, the center a note. Can you see that in the chat?
Yeah,
I can see
yeah,
my
it's
chat.
come
Let's
up.
hope they can. Let's hope they can all. Feels like we've
Oh.
disconnected.
We've gone completely now. Maybe we'll be back in a minute.
It's obviously the connection is it in Phoebe room? Matthew, can I just use this time wisely while we're out? I thought that was excellent. I could see how our staff and our partners and everyone could tangibly relate to that. That is the best I've seen the ITNs, you know, especially to people who are hearing it maybe, but aren't involved in the kind of detail of it. I thought that was brilliant. Really, really brilliant.
Oh, that's great. Thanks, Betty. I will pass that back to the team.
Yeah,
I'm sure it would have been even
it,
better if they'd have been doing it rather
I
than
know.
me. But
I'll put that in the chat. And the
Thanks
only
very
other thing
much.
I was going to say is about using people like TLAP to help us with co-production, because we're using them, and Social Care Futures. They are experts at co-production in this kind of thing, and they are brilliant too.
Yeah.
And they'll be brutally
Great.
honest. But yeah, I thought
that's
it was
very
brilliant.
Well, thank you. That's really helpful.
Hopefully will be brought in. We're having a session on Thursday.
So it looks like, sorry, Karen, it looks like IT's cut out. This sometimes happens with ONS meetings where we've lost our broadcasting.
Right.
It's because it's a public meeting. And it happened at the last ONS, and it happened for about an hour.
Oh gosh.
And
it's still
I'm
quite
going,
a lot of meetings.
I'm going to Teams Louise just separately on her BCP in case she didn't get that. Who's
She's
the
popped a message,
organiser.
Betty, saying the screen's gone down at their end. It's that
It
blue
may not.
room, isn't it?
It is that room, and it may not come back up.
No.
Okay, so
Looks like we might be.
maybe. Doesn't look like we're back, does it? I think we hang around for 10 minutes, 5-10 minutes, and then if we're not back in, we'll have to make a judgment, really. Although, Scott, you're presenting BCF. Is Scott in the room? Is he not? Or...
Yeah, Scott is. Yeah, I mean, if obviously we're not back on by past, I would need to. Oh.
No, we can't hear. So I'm going to say no. I've just come back for no.
Does that mean that they can hear us?
Not sure. Maybe. Scott, you look like, are you in E1 by any chance?
So I'm in the office, yeah.
So if need be, you could go to VB if need be.
Yeah.
Let's just see what the guys say. They're trying hard. Yeah, just give it a bit longer. Okay.
I think, Scott, I'm going to have to leave you with it, even if it comes back, because even I don't want to start and then have to go halfway through, obviously.
No, because Gillian said it's okay for me to present it. Yeah.
I'm just thinking, Scott.
Yeah.
If we need to hedge our bets here, always thinking ahead. Do you think it might be wise for you to walk up to Phoebe?
Yeah, I can head over there.
Would that be okay? And you can be in the room for that item then. And we've covered our kind of, if we can't get back online, at least you'll be there to share the presentation. Is that all right, Scott?
Yeah, I'll make a way there now.
Yeah, thank you.
All right, I might see you on the screen in a bit.
Yeah, hopefully.
Oh, wait. It's like, do you think he's going to come back on?
So I've just had a text from Patricia Miller say.
Oh, here we go.
Oh. I said you were trying to fix it.
There we go. Can you hear us okay?
Perfect. Welcome. Can you hear us? You can hear us online. Oh, good. Right. Sorry about that. The technology failed. We'd actually just got on to if you want to catch up on the integrated neighbourhood team conversation, you can probably catch up on YouTube on the stream. So, but yeah, the Ultimate the Better Care Fund. Gillian was just starting to introduce it, but I don't know whether you want Zena to.
Do you want to step in, Zena, as you're still here, if you're able to? I know this is one we can cover really briefly, isn't it?
Yeah, we've got Scott on his way round to the room in person as well, so in case we didn't come back. So yeah, afternoon. Yeah, I've got just a brief presentation to summarise the report that I think you've all had previously, because I think I understand from the last board there was a request to provide a bit more of a context to the matrix that were provided. So if I just share my screen, let's hope this works. Can you see that?
Yeah, that's fine.
Yeah. Okay, so let me just. Okay, so this is about Q1 report, and it was submitted to NHS England on the 29th of August. And as you know, it has to be signed off by the Health and Wellbeing boards as part of the conditions of the Better Care Fund. And this is just associated with the discharge fund, so it's not the whole of the BCF return. It's just the Q1 of the discharge fund, and then obviously Scott. We're fortunate we have Scott, who's the Better Care Fund manager. So this just shows the components of the main Better Care Fund, the income streams, and obviously this again, like just to say, this return is just around the 6.6 million, the Adult Social Care Discharge Fund, but just thought it's quite helpful to see where the rest of the contributions of the fund come from. Okay. So the aims of the Adult Social Care Discharge Fund is about reducing delays, so ensuring people who are medically fit to come out of hospital do promptly, so we create that flow within the hospitals, supporting the workforce, making sure we've got enough, capacity within our workforce, within the care market and internal to support discharged patients. And then there's a sort of get out around the flexible use of that to meet the needs, which can change obviously throughout the year, to meet those needs of people coming out of hospital. And we use that around discharge to assess model. Okay, so this really is how we use the fund in BCP. So it's around pathway 1, and that's rapid response reablement. So it's always about home first. So if we can provide that wraparound support and therapy at home, that's what we try to do. And that some of that funding helps those services. Pathway 2, which again is about people that are ready to leave hospital, medically fit, but can't go home for a reason. Maybe they still need that bit of reablement, that rehab. So they go to one of our bedded facilities. And that's around Coastal Lodge and Figbury Lodge, which is again reablement and rehab in a D2A bed. So that's discharge to assess. So they have their assessment while they're in that home. Also around self-funders, we also have a duty to support self-funders, so providing assessment and guidance, so they access and they purchase the right care for their needs. So that they spend wisely and they have that right guidance and support. And then finally around staffing, this is around this last quarter, staffing to provide deprivation of liberty safeguards and best interest assessments to ensure that we provide the highest quality of care to everybody. So discharge fund quarter update. So this is just again some very high level activity in the last quarter. So we had 79 people access bed-based reablement services. So that's the Coastal Lodge that I just alluded to. We had 179 support for people that were self-funding for assessments. There was 221 people referred to community-based intermediate care services. So that's like our PICS and BICS rehab services. And then we've managed to recruit a manager for the DOL's best interest assessment team to support that team. So again, it was just about the matrix that we had to return to Department of Health. And then the next bit is around the mid-year report that we're currently working on, and again that will have to come back to the Health and Wellbeing Board for approval. So hopefully in the next one we'll be able to have a quite a detailed report on the mid-year. Any questions? Very quick whistle stop.
Thanks for that, Zena, and the sort of slightly wider context from what we had last time. So that's useful. Now we are asked as a Health and Wellbeing Board to retrospectively approve this Q1 report, but any questions or points you wanted to raise, or particularly to ask Zena or Gillian, but hopefully by the sounds of it, then the next meeting we'll have at the half year point, we'll have be able to have a sort of better, deeper discussion if there's sort of points raised. Sam, did you want to just?
Yeah, just a really quick point. It's really nice to see the activity actually by quarter, because it brings the spend to life a little bit. At some point, it would be also quite nice to be able to put that against performance as a system. So can we make any kind of judgments about whether things are getting better or worse based on the way that we're using the discharge fund? So it's just a note for future reports.
Thanks, Sam.
Yeah, I think that was useful when you looked at those numbers. It's good. 500 people in the first quarter, you know, sort of access the different services through that, so it gives it some sort of scale. Yeah. If there's no other points. Anybody? Like Scott's come into the room. Can okay. Well, I will ask just to ensure that we do it officially. The Health and Wellbeing Board are asked to retrospectively approve the Better Care Fund Q1 report. As members of the board, are you happy to do that? Yeah, everybody's nodding. Nobody's shaking their head. Nobody's vehemently against. So that's good.
Thank you.
Thank you for that, and thank you, Zena. I know you've got another.
Yeah. Thank you very much.
Thanks. That's great. Okay. Picked up a bit of time. So, right, the next agenda item 9, refreshing the strategy. So, yeah, this is goes back to previous discussions we had about the health and wellbeing strategy, and then the need to refresh it. And I know Sam's been doing some work on this. So, Sam, if you'd like to present this one.
Thank you very much, Chair. I'm not going to spend too much time on this because we've had a lot of PowerPoint this afternoon, so I only really want to show you a couple of slides, if that's okay. The board and board members will be aware that we did have a development session on this quite a long time ago. We had a really helpful discussion of the approach to refreshing the strategy. So today in the paper, there's just 3 recommendations that I'd like the board to consider about how we go forward with the process. And just by way of context, I'll just show you a couple of things. I think the reason for bringing it now is that quite a lot's happened. So it feels like the right time to refresh the strategy, not least because there's now a new corporate strategy and a vision for BCP Council. Some of you will also be aware public health disaggregating. We've now got the NHS Joint Forward Plan in place with some very clear outcomes. So it felt like a good time for the health and wellbeing strategy to be having a look across some of those other plans and strategies. So I'm just going to talk you through a very brief proposal for how we get the thing finished. And not least, we need to consider the relationship with the place-based partnership. We're going to have a quick discussion under agenda item 10 about the recently forming place-based partnership. So I think this is the key slide for me today. If you don't remember anything else, but just remember this, that's fine. Above the dotted line is a suggested strategy refresh process. We've already published the JSNA. We need to go through a process with the board of agreeing what the high level priorities are within the health and wellbeing strategy that reflects the ICP strategy. So that's a legal requirement. We have to reflect the ICP strategy, but we've also got space within it to localise what we focus on as a health and wellbeing board. And that's where the council plan connection is really important, and also the connection to some of the ambitions around how the NHS is changing. And we've heard quite a lot today about the opportunity there with neighbourhood teams. So by the end of that process, we'll have a refreshed health and wellbeing strategy for BCP Council. But below the line, it's also key that we follow through on this process, which is more connected with delivery. So one of the things that was really clear in the development session was, what's the point of having a strategy? Actually, lots of people are interested in this idea of from strategy to action. So if we can focus a little bit more on the important programs that are going to deliver against some of those priorities, can we get perhaps fewer things in a rambling strategy and a more focused delivery plan. So one of the issues that we're asking the board to support is to workshop a session with the place-based partnership, so that once we've got that framework in place through the strategy, we can then agree what are the really important pieces of work that are happening across the system in the BCP Council area that should actually start to make inroads against those priorities. And that could be a mixture of commissioning, it could be a mixture of transformation and service improvement, and the final bubble, if we're maturing as a partnership, we'll get into discussions about how we approach resourcing, reporting and governance. So that's the key slide really from today. The only other slide that might be helpful is just a reminder of the broad priorities within the ICP strategy. So this is just a descriptor of what we mean in each of those three boxes. Sort of fairly self-evident, but they do describe slightly different things. And then this is a piece of work that we shared with the place-based partnership last week, just to show a number of examples as to where they might fit. So this isn't intended to be prescriptive, it's literally just an illustration of where you could put some of this work within and aligned to the ICP strategy priorities. So without further ado, I'm going to stop sharing and suggest we go to consider the recommendations, Chair. Happy to take questions.
Yeah, thanks, Sam. So yeah, we've got a few recommendations there. Thanks for keeping that sort of brief to the point. Any questions, comments from any members in the room or online?
Just
Patricia.
So thank you for that. It's brought another question in my mind, which is we're doing a medium-term financial plan, and we're not due to submit that to NHS England until the spring, but we will have finished it in December in anticipation of starting some of the transformation programmes in the new calendar year. And health partners are coming together on the 5th of November to just sense check where we're up until now. What was going through my mind over the last few days is we might want to bring health and local government colleagues together sort of the middle of January, because by that time we'll have finished our NHS plan, you'll probably finished your council plans and the finances, and it sort of makes sense then to look at the three plans and see where there's overlap, where we need to work together on the priorities and agree how we're going to do that. And if you're thinking about having Health and Wellbeing Board plan refresh workshop before that, that would all sort of come together for quite a nice start at the beginning of April. Yeah.
Yeah, I think the timing works really well. So a couple of points in the paper are that we'd be aiming to sort of publish the formal refresh probably January, realistically, but to have that workshop with the place-based partnership in November if we can.
Yeah.
So I think that would work really well.
Brilliant. Good. Thank you.
Okay, thanks for that. Yeah, any other sort of comments or additions to the discussion?
Chair, I have my
sorry, Matthew.
hand,
Matthew,
hand up if it's okay to come in. Sam, I don't know whether my comment is best placed under this item or under item 10. But I guess the comment I wanted to make is I think within this strategy and or the work of the place-based partnership, I think there's something missing at the moment, which is the work that we need to do around health or the interaction between health and local authority services that should be done at the level of place. So this might show up under your heading, working better together. But I think if you think about services such as an approach to frailty or such as models of long-term condition management and how we're going to deliver the move from care within hospital to out of hospital, or you think about the health agenda for children and young people cutting across both physical and mental health, those are all issues where it would be helpful to be developing an active approach at place level. So there will be some work done at integrated neighbourhood team level. There will also be some work done across the whole of the integrated care system in terms of high level principles. but we've got a real opportunity, I think, within the BCP area in terms of the coterminous nature of the council boundaries and largely the core catchment area for UHD as the acute trust, and Dorset Healthcare being very present in the community. And I think we need to consider, therefore, how those bits of work around health pathways are done, either through the strategy or the functioning of the place-based partnership.
Thanks for that. Sam, did you want to?
Only to agree, but I think it sits more in the delivery plan of the place-based partnership. That's where we need to focus on how we're going to make a difference in BCP, in my opinion.
Okay, thank you.
Thanks for that. Thanks, Matthew. Any other sort of comments on refreshing the strategy? I know it's got some history, hasn't it, from the workshop we did, I think December last year, wasn't it, which was really useful in terms of, I think the feedback we had was we didn't want to spend months and months working on a strategy. We wanted to sort of light touch refresh of the strategy. We want to focus on the sort of actions, and I think this, thanks Sam for your work in sort of putting it into the right sort of context and getting things to the right sort of boxes to help our thinking, our sort of strategic thinking, but not just that, but actually the actions. And I think for me, it's quite important with just some of those areas that you've sort of mentioned there. We've got the transformation programme, Fulfilled Lives, the NHS plan, changes within public health, changes within UHD that are going on in the next year or so. There's and as well as the integrated neighbourhood teams that we've already talked about. So there's an awful lot of shifting places in the area in terms of health and wellbeing. So I think to have that sort of light touch strategy, actually make sure that it gives it a context and get it all sort of moving in the same direction, actually delivering some outcomes. So so what the recommendation is that board members agree to adopt the main ICP strategy headings. So that's the prevention and early help. Prevention and early intervention, thriving communities and working better together, and construct the strategy to reflect these. And board members agree to participate in a simple voting process to select the most important issues under each of the 3 themes. From this, the final strategy will be developed. And board members are asked to endorse a workshop involving the place-based partnership officers to identify the main programmes anticipated to deliver against the themes in the strategy to ensure alignment. Are all members of the board content to approve those recommendations? Or looks like people are nodding. Haven't got any shaking heads. Haven't got any dissent. Is there any dissent? Anybody not content or wanted to make any changes? Good. It's a good bit of work, Sam. Thank you for that. That's endorsed. So agenda item 10 then, the update from the place-based partnership. Gillian and I think Gillian and possibly Kathy were going to update us.
Yes, thank you. And this follows seamlessly on from the item that Sam's just presented. We've mentioned a few times through the course of the meeting place and place-based partnerships, and the increasingly important role that place and then neighbourhoods we expect to play within our integrated care system. And in the same spirit in which we're approaching integrated neighbourhood teams of Just Start, that's what we've decided to do in terms of our place-based partnership here in BCP. So some time ago, the Health and Wellbeing Board, I think, agreed that the place-based partnership should be an executive owned by the Health and Wellbeing Board. And so the first meeting of our place-based partnership took place last week. And thank you everyone on the Health and Wellbeing Board for either nominating someone to represent you on that group, or to be part of that group, or in some cases come along yourselves. The meeting included representatives from across BCP Council, and this is really important, from the Wellbeing Directorate, from Children's, and also from Operations, the real place directorates, and of course our Director of Public Health and Public Health teams. As well as from the ICB, from Dorset Healthcare, from University Hospitals Dorset, and from Fire as well. So thank you to everyone for being there. The group welcomed the kind of sense of getting on with it, of having a place-based partnership. We agreed that collaborative efforts could lead to some really significant improvements in areas like frailty, childhood, obesity, but also just increasing our overall impact on helping people to stay healthy and to lead fulfilled lives. we discussed in a bit more detail the proposal to refresh the health and wellbeing strategy, and for the place-based partnership to really step into a role as an executive group, driving that forward, driving the priorities forward. And the group kind of agreed to take on the challenge and to accept it, and to have a workshop getting into a bit more detail on that. We started to share some examples of how this has been done in different areas, how different areas have done place, if that makes sense. We had a discussion around the West Yorkshire ICB's approach, and we thought that it might be good to share some other really tangible examples as a way of taking our thinking further forward. There are governance questions around place-based partnerships that have been around for quite some time, and I think in some ways sometimes the governance question can get in a way with the getting on and doing something. But where we were absolutely agreed was that form needs to follow function. Our focus needs to be on delivery through collaboration and making an impact. To start with, our form is pretty informal. Over time, that may change. We may move towards more formal structures like a joint committee. If we move into delegation of budgets and so on, that's something that we would need to address, but we can cross that bridge as and when we come to it. So we're very much meeting as the place-based partnership, not to talk about what a place-based partnership should be. And I think that's a really important progression. I think there was an agreement that we will need to have some priorities to work around. Again, that sense of sometimes if you try to boil the ocean, if you try to do everything, you don't make progress further forward. And so that piece of work with the Health and Wellbeing Board really draw out what are the priorities to go into the strategy, and then we spend some time saying where are the places that we can really add value through that collaboration. Will be really important. So the place-based partnership is up and running and ready to work in taking that strategy piece forward. And Kathy may want to add something as my co-chair of the partnership.
Thank you, Gillian. I think you summarised that really well, but there was an absolute keenness not to talk about what it could be and actually recognise the group as it is, the place-based partnership, where we will begin to do the work, and a recognition that it will be messy to start with, but through that and through the priorities driven by the Health and Wellbeing Board, we will then come to a place, and as Gillian says, and set out maybe some governance, but we were very clear that we needed to understand the functions before we set out in terms of a structure and a form.
Great, thank you for that update. Actually, that's for me as well. It's just quite a useful insight to understand that you're actually meeting as the place-based partnership and not just to talk about what place-based partnerships are. So, yeah, any questions or comments from any colleagues? Patricia.
Thank you for that. I agree. Function and then followed by form. It'd be really helpful at some point to sort of get an idea of the time, form and governance, because obviously we definitely in health would like to develop some commissioning responsibilities down to place, and obviously that requires a maturity matrix and us being really clear, but understanding what the timeline for that is will be really helpful. I mentioned the local trust earlier on. They are the partner working with government to design the foundation of the Health of the Nation plan, which is neighbourhood and place. So I would expect that given the current government haven't been the architects of current policy, that we'll see something slightly different coming forward following the spring that might just reshape what we might be doing slightly, but not significantly.
Thanks for that. Any other comments or additions to? No. Okay. Thanks, Gillian, for your update. That's really helpful. So we will then, we've got 10-15 minutes just to move on to agenda item 11, the access to services principles. And I know Sam would contact me about sort of including this. I'll let you introduce.
Thank you very much, Chair. So I think I've already made my pitch on this item in connection with Amy's excellent presentation earlier. This is a piece of work that's come out of the National Network of Poverty Truth Commissions. People don't know what Poverty Truth Commissions are. They're very simple. You take 12 ordinary members of the community who've struggled with poverty and other conditions, and you bring them together with 12 people who sit in positions of power, if you like, in public service. And we sit for a year and we work on issues that come up through the commission during that year. The first Poverty Truth Commission took place in BCP Council, started in 2022. I sat on that commission as a civic and business commissioner along with Jess Gibbons and a number of other local leaders, and we had some excellent community commissioners. One of the task and finish groups was on this concept of what's called humanising the process. And it was based on people's direct experiences of how they'd been treated when they'd gone through various attempts to access support from the public sector, not just councils, not just the NHS. There was a whole range of examples in there. And actually told a bit of a story that often when people are under pressure, particularly working in frontline services, there isn't time necessary to stop and listen and to find out what's happening. So we did a quick piece of work, coming up with almost like a charter of what it feels like to be having services or being a member of a team, if you like, that was working around you, that has adopted those positive expressions of what it feels like to genuinely be treated in a human way. Funnily enough, lots of other Poverty Truth Commissions have come up with exactly the same experience. So this is a set of national principles which has come out of several of those commissions. It's been brought together and it's been published by a group called Amplify, which is almost like the campaigning arm of the Poverty Truth Commission network. And so I'm just asking the Health and Wellbeing Board today to sort of consider those principles. I think if you would be minded as a board to adopt them, then the ask is for leaders on the board to try to look for opportunities to work with them in the various services that you're connected with in your role as a Health and Wellbeing Board member. So I don't think there's any surprises in them. They all are very common sense things to do. Our challenge is that sometimes it's difficult to create the right kind of environment for that to happen reliably, but it's something that I think we should all aspire to. So I'm just asking the board to adopt and endorse them today. Thank you.
Thanks, Sam. Any comments or input on those? Had them all circulated before, and I mean, I will comment. And I know Sam sort of contacted me about it before, and when I sort of reflected on it, it's we often talk about health inequalities, and for me, this is the key, isn't it? It's making sure the door is open for people to sort of to get the help that they need, and that's got to be the sort of the key to sort of addressing health inequalities. That's got, for me, it's got to be the major key. So yeah, in the appendix 1 there, should we run through, because what we're being asked. Oh, Kat, sorry, Kat, did you want to come in and comment?
Thank you, Chair. Just to say, as you would expect, we fully endorse this coming from a communities angle. It underpins all of the work that we do in terms of the Access to Food Partnership, the age-friendly communities work, the community development work that we do. It's absolutely fundamental to taking that public health approach to addressing the root causes of things and intervening early. So absolutely embrace this. I just need to encourage people to enable the staff to have the time to do it properly so that it is meaningful. I've had an example come through to me today from a person who's been homeless for 3 years because the appointments that are set for them are set at the times that don't meet their needs. They're unable to access forms online digitally. So that whole thing about listening to the person and what it is that they need in order to turn their lives around is absolutely key. So really pleased we brought this forward, Sam, and fully support it.
Thanks for those comments, Kat. That's really helpful. Yeah, I'll just quickly read through. So the principles are about consistent and connected services from cradle to grave, a whole person and whole community approach, services when and where people need them that everyone can access, dependable and supportive relationships, and everyone is treated with dignity and humanity. And there's within the slides there's sort of, it expands on those as well. If there's no other comments. Oh, sorry. If there's no other comments, got two recommendations. So as board members consider adopting the access to service principles as I've read out, which are in your appendix there on the report. And members are also asked to share these principles within their own organisations, especially where transformation work is taking place, involving contact with customers, appointments, assessments and other services. Is everybody content with those recommendations? I do like chairing a board that's not politically sensitive and doesn't have amendments being made and doesn't. But I think but equally, and I know we're just coming to a close, we'll go on to the work plan in a moment, and I know a few of us got other meetings to go on to fairly swiftly, but for me, we've covered some really quite key issues that for our health and wellbeing board here, and there's quite a few areas like that last one about access to service principles, but other areas that we've discussed about age-friendly communities that for us to take back to our organisations and make sure that there is not just awareness, that information is shared and that practice is changed and actually we're delivering what we need to for residents across the Bournemouth, Christchurch and Poole community and further afield. So so I know, although quite a few of us are going straight onto other meetings, please remember that, and actually, you know, I'm really grateful if everybody sort of actually took those on board and actually spoke to colleagues and actually enacted some of those things and shared information and came back to those people who've been presenting the reports and have those discussions and questions and sort of get involved in these areas. So right, a few minutes left. So we've got the work plan, agenda item 12, to consider the board's work plan. We had quite a lot on the agenda today, and I'm glad I've kept you all in order to arrive on time. January meeting, we've got the Safeguarding Adults annual report, which is a regular report which we'll have seen before, and Community Action Network. So I'd had some correspondence with Karen through others that the Community Action Network for the board to be informed of the work of the Community Action Network. So I think that would be really useful in January for us to, and quite a few of us will have had contact and will be aware, but actually to share that with further afield actually. So other than that, I think we'll have obviously regular items coming on. There's other items which actually haven't been allocated to meeting dates, but I'm sure we'll have more added to the January meeting, you know, whether it be Better Care Fund or others coming along. So there's no other questions or comments. We are 3 minutes ahead of budgeted time, so I think we've got time just for a quick drink before the next meetings that a lot of us are going to. So, and for those on the Integrated Care Partnership, I'll see some of you tomorrow morning in this same room. Just to remind me, as a colleague reminded me earlier, I was about to hit the road to Dorchester in the morning because it's always at Vespasian House in Dorchester. And then they said, oh, it's in Phoebe Room, isn't it? And I checked and I thought, good, I'm glad I'm not on the dual carriageway when I realised I'm going in the wrong direction. So I'll see some of you in the morning. Thank you.